Dr. Francis Lee Stevens, welcome to the Science of Psychotherapy podcast. Great to see you.
Yeah, I'm excited to be here.
Yes, and Richard here. Very excited to talk about this book. This really caught my fascination when we heard about it. So great to have you.
Yeah, excellent. Yeah, I'm really excited to get the word out about this book. It's something that I've been kind of working on and brewing for a long time. It's the Affective Neuroscience and Psychotherapy, a clinician's guide for working with emotion.
Now, before we jump into the book, let's introduce you. Let the listeners know sort of a bit about your background and then how you've come around to, conceiving and writing this book.
So I'm a psychologist by training. I went to Tennessee State University. I did my internship at a counseling center, University of Rochester. I did my postdoc in neuroscience at the VA in Salisbury, North Carolina. And I taught at a number of colleges in Boston for several years, teaching, all sorts of social psychology, clinical psychology, neuroscience classes. And now I work in a private practice out in Worcester, Massachusetts, and I still continue to do research and write. And so in my training early on, I think I started off training as a master's degree in cognitive behavioral therapy. And as I went on, I did a PhD in psychology, and that was kind of focused more on a psychodynamic bent. I think they were focused on object relations theory. And I always felt like there was kind of something missing in these different paradigms. If you know anything about kind of cognitive behavioral therapy, it has the ABC model, right? So there's activating event, belief, consequence, and the goal is to make an intervention at that belief, to change your thinking, which changes the consequence or how you might feel about that. And for a lot of like psychoanalytics, psychodynamic therapy, I trained 1 year at the Boston Institute for Psychoanalytic Therapy, BIPSI, and it's all about insights, right? So if you go back to your childhood, you understand that better, right? You see where things went wrong, that insight, will solve the problem, make you healthier. And although I saw that there were some benefits from these interventions, they never quite seemed to encapsulate all of my patients' problems, all the clients' problems, never seemed to quite fix everything. A lot of times I felt like they were left lacking. And so the whole idea here is the paradigm is based around like thinking, right? You change the way you think, the way you understand something, your insight, how you think about something, and that changes how the way you feel. Now I did my postdoc in neuroscience with Kathy Tabor at the VA in Salisbury. And there's very little evidence showing that by changing thinking, you change an emotion. All right. If you look now at the research in neuroscience and memory reconsolidation, you see that actually, if we really want to change emotion, we need to kind of change that with another emotion. You don't really change that through thinking.
Right.
And so as I learned more about these different types of interventions, I studied interpersonal therapy in my internship. And I was reading about Leslie Greenberg's emotion-focused therapy and Diane Foch's accelerated experiential dynamic psychotherapy. I started seeing the role of emotion and how much that played. And so I kind of used that with kind of my training in neuroscience to kind of look at how does this fit together? How does the brain work and really respond to emotion? And that's kind of what the book's about. And in my own therapy, I kind of found this working of taking this emotion-based approach to psychotherapy versus kind of a more kind of cognitive approach. And I found it been much more effective with my patients over time.
Yeah. Now and so this is what you've laid out in the first part of your book, isn't it? So the first is about the scientific background, the need for a new approach to therapy. Can you just talk to us a little bit about what you lay out there in part one?
Sure. So part one's kind of the science behind that, or part two is more the practice.
Sure.
And so part one, I took a little bit about my background and what got me interested in this and how I came to see emotions as so primary in psychotherapy. And I look at a lot of the evidence from throughout psychology of how emotion influences our memory, emotion influences our attention, our judgment, our thinking, right? And so we see all these aspects, all these studies of how we how emotion affects all these other kind of cognitive and processes and behaviors, right? But if we look at the kind of the majority paradigms in psychology, they're all kind of thinking-based interventions, and no one's kind of looking at the other way around. Now, that's not to say that thinking has no effect on emotion, or thinking can change our behaviors or have influence. It's just saying that the way the field of psychotherapy is laid out right now, it's kind of overly balanced in terms of thinking and not enough on emotion. And so I talk about all the different processes of how emotion affects them. Then I go on to a third part, looking at kind of the basic brain structure. And so I go through and talk about the different brain anatomy, different brain parts, and their role in emotion. And that's kind of a guideline for readers. And so when you read this book, I don't recommend necessarily read it cover to cover like you might a novel, but to kind of go through and read what might be interesting. And then as you want to maybe learn more about the brain, kind of make me go back to some of the references and read a little bit more about how that area of the brain is involved in emotion and what it does. It can be kind of dry, just kind of go through and read the different parts of the brain, but it creates a nice reference towards how different areas of the brain work together in processing and understanding emotion.
You're a man after our own affect, really.
Oh,
I was thinking of, a lot of people that are aware of this, but in my first career or my early development as a psychotherapist, I was a professional actor. And it actually has been really useful. In fact, almost everything I know in psychotherapy, I also learned in acting school. And this just reminded me of an exercise that we did early on in acting school, where we had a bit of dialogue we had to learn. So we all went off and learned it. And we came back the next week and in the class, and we were told to perform it with this emotion, and then do it again with this different emotion. So we were using exactly the same dialogue, but with a different emotional reference and framework. And I tell you what, that changed the way we thought.
Yeah, there's one supervisor always said, there's what the client is saying, and there's kind of how they're saying it, the emotion behind it, right? And so I was actually an improv comedian, and one of the games we played was like I should have said, or something like that. And you would say something, but the inflection and the intonation changes how that line comes across totally.
Yeah, it's something that's really important. This I think there's one thing that always strikes me in something that Joseph Ledoux said, is that emotions have to happen to someone. That when you're having an emotion, there's generally a sense of self in the experience, although we do have basic stimuli and various things. And so when you're looking through the chapter headings, we're looking at this interesting things. I'm just looking at a few of them as I go here. Awareness of your emotions, the validation, a sense of self-compassion, and emotional regulation. And one that I really love, which I'd love you to talk about, is affect reconsolidation. So, but this idea that this thing is happening to someone, how does that resonate in the frame of what you're talking about?
Yeah, well, let me talk you through kind of like how the books outline those various chapters, right? Because I put them together that way because I see that kind of common common linear projection in therapy, that they kind of go from one to the other, right? So I start off with mindfulness as the first chapter, and that's all about kind of raising emotional awareness, because if you're going to work with emotion, the first thing you have to do is be aware of it. And then you want to validate it, all right? And this is a very underused tool, but very important to be able to really say, this is what I'm feeling, so people understand that. And then to have some self-compassion for it, right? To be able to be kind to your feelings. I tell people, your feelings are your feelings. You can't change how you feel. You can only change how you respond to your feelings. Some patients feel guilty because they're sad, or they feel, bad that they're angry, but they can't change if they're angry or they're sad or whatever they feel is what they feel. You can't change that. You can only work with that. And so that's really about trying to accept those emotions as to what they are. Those first three steps, just being okay with whatever you're feeling. And then after, we want to regulate that emotion to about a moderate level, right? So people that are overly emotional, they struggle with impulsive behaviors, they can't manage, that they're going to not be able to kind of engage in psychotherapy in that process because they're overwhelmed. And so you want to downregulate that. But then some people are kind of shut off and they're dissociated from emotion. You see, like with PTSD, you need to upregulate emotion then to kind of get them more aroused. And when you're in that moderate level, that's the most effective for psychotherapy, research has shown. And then I talk about how to kind of work with different emotions, like maybe setting boundaries if you're angry, or how to work with acceptance if you're feeling shame. And then the last chapter is about affect reconsolidation. It's really kind of changing kind of underlying baseline emotions. I use the term affect reconsolidation. Basically the same term would be memory reconsolidation.
Yes.
You might see that.
Yeah,
I call it affect. You're not really changing the memory, you're changing the emotional nature of the memory.
Yes, absolutely.
And this really fits in with what Ledoux was saying, and some of the things that our own conclusions, Matt and I have done, is that it is a part of what we remember, which is really what makes up the self and the nature of memory and how it links in. And of course, what's beautiful in the book is that these work you do with the different emotions. I mean, these are specific sort of interventions that you can utilize along therapy. You give people specific tools, which is really fabulous.
Yeah, a lot of times I think emotions are something that people see somebody regulated, right? Like I'm angry, so I need to calm that down. I need to regulate that. Like I got to get rid of that. When really anger is a form of self-protection, right? And so anger might be about setting boundaries, or if we're angry towards ourselves, it might be about self-forgiveness, letting go of that anger towards ourselves, forgive me, giving it back to our old self. And so I talk about all these ways to kind of work with and utilize emotion, not just to regulate it, to get it to where it's like, okay, I'm not anxious anymore, but to listen to that anxiety. What's that anxiety telling you? Maybe you're afraid of something about yourself that you would need to work on, accept and work through, or reconsolidate, and not just try to get that anxiety down to a low level so you can kind of out the door and on your way.
That is such a good message and paradigm shift that, the negative emotions are not just something that we need to get rid of. They actually have utility and they have extreme value in the therapeutic process. So, yeah.
Yeah, we feel the way we do for a certain reason. It's not just, because, a mental health problem, right? The mental health problem is the secondary emotion. So if you look at kind of Leslie Greenberg's research on emotion-focused therapy, says, people, feel depression when they're in a kind of a stuck state. So say someone dies, right? You're going to feel sad about that, but maybe you don't want to feel sad. Maybe you don't want to deal with it, so you push it down. Okay, but you actually, your body wants to feel sad. It wants to mourn that loss, right? So it's kind of pushing up that tension that causes depression, and that can last forever. It's suffering. We study Buddhism. The way we can fix that is, as therapists, as psychologists, we try to take the lid off that and allow ourselves to accept that sadness. When we accept that sadness, no longer are we stuck feeling depression.
Yes, that's right, because it's the other affective disorders that emerge out of the difficulty or the difficulty of managing an emotional state.
Exactly, right? So, maybe you're anxious about something, but maybe you're anxious about something you did a long time ago. You got shame around that, but you don't want to talk about it, right? The anxiety is a manifestation of this other emotion. And when we can work through and accept the anxiety and see what's behind that and accept ourselves or forgive whatever it is, or to move past that, then we're not going to have that secondary state of emotion. So things like anxiety and depression, these psychopathology, these are just symptoms of a larger problem, not just something we want to just manage the emotion for. We want to try to understand the larger problem behind it.
Yeah.
Yeah. This comes with, sorry, Matt, you go.
Oh, no, I was just going to say another way to talk about the same thing in a different way is in talking to therapists who just purely use a cognitive approach. What do they miss out on? What are they missing?
Yeah. Then this is what you were saying in the beginning, wasn't it, Lee?
Yeah.
That you found it missing.
Yeah. So I'll give you one great example of kind of where I came up with this. When I worked at the VA, I got a lot of veterans with like road rage. It was kind of a common thing. And they come to my office and they would say, oh, I got angry. I'm sorry. It won't happen again. I got to just manage my anger. I got it taken care of. And, you could kind of work with them to maybe deep breathe or, develop tools to manage their anger, which are good, but that's never going to fix the problem necessarily. Yeah. Right. And so if I could get them to kind of stay and we would talk with them, I understand that they had a lot of like trauma from their childhood, trauma from going to wars they want to go to, doing things in wars they want to do, right? All of these things are boundary violations, right? You're being put in a situation that goes against who you are, your integrity, right? So of course you're gonna be angry about that, right? So these guys had good reason to be angry. The problem is that they were misattributing it. So all your emotions are valid, they're all important, they're all real. They're just not always germane to the current situation. So what happens is some old lady would pull out in front of them, which makes us all a little bit angry, but these guys would go into a rage because it would bring up all their anger from the past, right? They're like, oh my God, overwhelmed with anger from all their past. And then they want to, run that lady off the road. And then afterwards, when that happens, they feel shame around that. Oh my God, what I do? I'm so sorry around that. They think their anger is the problem. So they're like, oh, my anger is such a problem. I'm so embarrassed by it. I got to get rid of it. If I could say, no, your anger is fine. It's what you're doing, your behavior. You can't act out like that. If we can accept that anger, all right, let go of it, reconsolidate it, change it, then you're not going to have those reactions. All right. But we got to work with all that anger from the past. Just trying to managing it in the here and now is not going to fix all the anger that's within inside of you.
Yeah, that's so important. This reminder, just quickly, I've got to share one of my cases from way back.
Sure.
And it was somebody with twins, and she had a SIDS death, so an unexplained death of one of the twins. And she came to me, actually was in a public venue, which was very difficult, but she said, everybody tells me to get over it and stop having this emotion. And I said, no, of course not. You've lost a child. This is a terrible thing. But to cut the long story short, I got to the end of it, and she started talking about she had a little shrine for the child, and I thought, well, that's nice, you got that there. Yeah. And I just sort of thought, how many pictures do you have of the child around the house? And she sort of spent a moment and counted up like 20 or 30 photographs of that. And it was one of those intuitive moments where I just sort of said, and how many photos do you have of the surviving child? And she counted around and said, oh, 4. And I said, there's your problem. You have an imbalance of, and so it's very similar to what you're saying. Validate. I mean, there's nothing invalidating or incorrect about the sad emotion, but let's just get it in the framework, in the context, in a livable experience. Your VA guy was very much like that.
And allow it to pass, to be like, I'm sad around this child, this loss, accept that. And when you accept that, that loss moves through you. And when you've effectively grieved the loss, then you can be able to enjoy the child that's still living the rest of your life. Okay. But if you don't allow yourself to grieve because you want to have the emotion, then you're going to be in that stuck state and you're going to be fixated on it.
Yeah. I suggested she had equal number of photos and she was very happy and went away.
That's a good idea, probably.
Yeah. So when we're sort of drilling down to the neuroscience of this, and we can talk about maybe the hippocampus and its role in attributing and making associations between affect and autobiographical memory and that sort of thing. Let's sort of drill down to some of the nuts and bolts of how these emotions become maybe unhinged from the here and now. You were talking about the soldier just before.
Yeah, it's like when you get emotionally activated, all right, and I see this in patients all the time, they get overwhelmed. They're often unable to make kind of accurate attributions for our emotions. In fact, if you look at the research in psychology, we often misattribute our emotions all the time, right? That we sometimes blame other people for how we feel, or we think, we give someone some caffeine and all of a sudden they think they're excited about something that they're not really excited about. Yeah. And so when we're overwhelmed, and this is where we might need to think about kind of some of those cognitive strategies, thinking, downregulate emotion. But when we're overwhelmed, we're very quick to misattribute our emotion. And so, if I'm in a bad mood for whatever happened to me, I might say, oh, this podcast is not going well. I'm upset about this. Why don't they ask me better questions? Yada, yada, yada. Right? Because I'm assuming my bad mood is about what's happening here and now. But that's often not the case. And so we have to be very careful about how we attribute our emotions. I often say, do you know why you feel that way? And if you don't, that's okay to my patients, because sometimes you don't know why you feel the way you do.
Yeah. And because you're on the Science of Psychotherapy podcast, you would never feel that way anyway.
There we are.
Of course, I feel so much better being here now, you know, and my wife's going to be so excited because I'm going to be in such a good mood. She's going to think it's about her, but it's really about you guys.
Yeah, that's right.
But this an understanding, and we're great believers that if you have some understanding of the science behind, it doesn't necessarily make you a sort of a technician, but it just gives you a greater depth of feeling of where they're at. So do you sometimes find yourself saying, I can feel this part of the brain firing up, or that part of the brain, and that helps you understand what the patient is experiencing? How does that enhance your experience?
It does. It really helps me understand the patterns I see in everyday psychotherapy. So, I don't go through with my patients and say, all this self-referential thinking, your default mode network's overacting and we need to calm that down, right? But in my mind, I might be thinking that, and that there's this area of the brain that can kind of get caught in a loop when we think about ourselves and overly focus on ourselves. And we need to try to break out of that. And sometimes things like mindfulness is very good to be able to separate yourself from your feeling or your experience. And so if I find that someone's, overly personalizing things or engage a lot of self-referential thinking, I might engage intervention like mindfulness to be able to try to tease that apart and not get kind of caught up in that network.
Yeah. It increases your empathy for the client, the patient as well, doesn't it? Because if you understand the mechanism, then I don't know. Well, for myself, it increases empathy for the client.
Yeah, I don't know. I mean, I think it helped me understand it more, right? So the more I understand the brain, the more I'm like, my clients are doing the best that they can, right? Yeah. I might think, gosh, why does this person that's, an alcoholic keep drinking? He knows it's bad for him, right? It hasn't helped at all. What's going on? But when you start understanding the dopamine pathways in the brain, right, and how that gets reinforced, then it's like they don't want it, but they're so craving. Yep. We understand the neuroscience. We understand wanting and liking are two separate things. So we can want stuff we don't like. So they know the alcohol is no good. They don't like it, but they want it because of that dopamine hit that's so powerful. And so then it's like I can appreciate and have more empathy and say, yeah, I mean, I don't have that dopamine discharge, but they do. And that's why they're struggling so much. It's not just a lapse of willpower or a self-destructive habit. It's that they can't stop that dopamine impulse.
And we need to actually do things that help change those balance of receptors and so on and so forth. Just all these little technical aspects, which probably is stuff that we learn in some of these neuroscience that you learned in your early neuroscience degrees. But I am fascinated when we talk in neuroscience, how much, I hate the way academia silos off things, and breaks things up, but we actually have affective neuroscience as a area of study and cognitive neuroscience as a sort of an entirely separate area of study. And it sounds like you went through those avenues and those sort of neighborhoods on the way to doing that. And that's what frustrated you, the disconnection. What was sort of the way you looked back on those, the way the academia were dividing them up, but you wanted to bring them back together?
Yeah, so it's really hard. It's a great distinction you make between kind of the affective neuroscience and the cognitive neuroscience. And you're right, the brain all works together. But it's hard not to simplify this stuff down when you're trying to kind of put it in terms of like, okay, what does intervention look like, right? So I talk about kind of the emotional part of the brain, the cognitive part of the brain, and how they don't always kind of mix and get along. But, if you really look at what's happening in the brain, all these networks are interacting, the cognitive areas, the prefrontal cortex and the subcortical limbic areas, there's all this talk between the two. However, there is some distinction, but it's not black and white. And so it's like, you have to be able to recognize like, okay, these distinctions, these knowing between kind of the cerebellum, kind of what they call like the reptile brain, and the limbic system, the more emotional brain, the prefrontal, more cognitive brain, right? It's helpful to think about it, but you also have to be able to know when to let that go too, because it's not one kind of three-part system here. It all mixes together.
Yeah, and I think the Connectome project has really highlighted that as well. Just looking at the interconnections, the highways and the freeways, between different regions of the brain.
And more and more we look at kind of brain networks, which is like
that's right.
Multiple areas of the brain, both kind of cortical and subcortical, working together, like the salient network, the default mode network. And so we see that it's like, okay, it's not just these different parts of the machine, but different kind of pathways together, and that helps us understand the function of the brain better.
And I think we also, sorry, Richard.
No, go on.
Just when we're looking at sort of PET scans and things like that, we might be under the false assumption that there's only these discrete areas of the brain lighting up at any one time, but we have to remember most of the brain is lit up most of the time. It's just that there are particular areas of focus at any one particular time, and I think we forget that this terribly integrated system is all working most of the time.
Yeah, it's hard, like when you don't want to publish a great academic paper, not to be reductionist and say, oh,
yes,
the amygdala is all about fear, and that's great, but these are oftentimes, the amygdala has, connection to the hippocampus and the, ventral medial prefrontal cortex. And so all this is interacting.
Yeah, I mean, there's one thing we try to talk about, certainly in our new book, that all this stuff informs us, but it mustn't constrain us.
Yes,
and as you say, limit us that reductionist idea. And I mean, one of the notes I made as I was looking through your book was I just put two things. That we try to that cognitive thing of you can think your way out of trouble. And then there's the emotionalists who say, no, we have to feel our way out of trouble. But what you're talking about here is that it's if you can understand the interaction and the integration and the interplay between those two processes, you're probably going to be ever more successful.
Yeah, so let me give you an example that I would give my students, because I think sometimes say, oh, you need to think more, use your head more, go with your intuition, go with how you feel. And really, this should be a balance, right? So, I tell my students, maybe you have an exam the next day and your friend says, hey, let's go out for some pizza and beer and have a good time. Well, right away, you might find yourself in a state of cognitive dissonance. I think I should stay home and study, but I feel like I want to go out and have fun, right? Right away. So that's kind of the mild level, first level pathology, kind of maybe where your thinking brain, your feeling brain aren't connected, right? But if we really kind of slow down and sit with this, all right, and listen to both our feelings and our thoughts, we have a thought and a feeling about both, right? We might feel like, I really want to do well in my school. I have goals, I feel like I've, worked really hard. I can go out. You might have a thought about going out too, which is like, well, I can ask my friends to go out tomorrow night, or, I think I've studied enough and I think it's okay to go out, right? And when you balance the thinking and feeling around both decisions, well, then you can make a sound decision to either go out or stay home. If you don't integrate the brain like that, what happens is you go out and then you feel guilty because you're not studying, or you stay in and you're mad, you feel sad because you didn't go out and have fun. You're not listening to you're not integrating the whole brain. So what we really want to do when we have a kind of a dissonance like that in the brain, where we have a difference between maybe how we think and how we feel, is not just to say, oh, go with how you think or go with how you feel, but to try to integrate both the thinking and the feeling around that dissonance to make the best decision.
Yeah, it's interesting, because what I see as we're talking about seeing the brain, of course, we've got these sort of separated elements but integrated aspects in the dorsolateral, which is looking at decision making, the ventrolateral, which is looking more at that sort of emotional engagement, and the orbitofrontal, which is looking for correctness or accuracy or rightness and wrongness. And they're all just sitting up there, in something the size of your fist. And we disconnect them, but they're all connected, yet they're all elemental parts that we can functionally use. Sorry, does that sound okay? I actually was just putting out there for your thoughts.
Yeah, I mean, it's like, what is it, the Mr. Spock paradigm, right? Where someone will be overly focused on thinking, or the Captain Kirk with the more kind of emotional thing, right? That we have kind of these two kind of, we can say we have kind of a separate feeling and a separate thinking brain. Of course, like we said, they're very integrated, but some of us depending upon our histories, we'll tend to kind of rely more on one or the other, right? So we like to think through things. I have patients that they have a problem, they just want to think about it, and they make these big decision trees, right? But if they're not paying attention to their feelings, they can never really make a good decision. And I have patients that kind of go with what they feel and what's going on. But we talked earlier about how you can misattribute emotion, right? And so when you do that, you might think, oh, I feel good, I'm going to do this, but really that feeling is about something else. And so you really have to integrate the two, right? All the brain together to make the best decisions.
Yeah. Oh my, that's the neurology of Star Trek. I'm just sitting here thinking, that's so true. Look at that. That's exactly what they do. They divide the brain up.
They divide the brain up. Yeah, it creates a great metaphor, and you can see them argue on Star Trek and how they solve problems together. But really, this is just our brain interacting.
But you've got Sulu, who is the one who finds direction. You've got the other one who's got the youth. You've got the communicator.
So they're all different areas of the brain, right?
Here we go. Here's a new book.
Well, that's
Lionel back there with the.
But it is an interesting point. Yeah.
Yeah, that's another big discussion on personality, differences too. When we're, as you say, some people are, more emotional and some people are more cognitive. But what have we missed so far? Because we're going to wrap up in a minute. So is there anything, Lee, that you'd like to sort of round out with?
Well, I can follow up on that comment about, I've done some research on some people are more emotional, more cognitive. And what we find is if you look at attachment theory, right? So something like anxious attachment and avoidant attachment, these are all just strategies to cope with emotion. So anxious people, when they're not being paid attention to by the mother figure, they get more animated, they get more emotional. They're trying to get the mother's attentions, where avoidant people kind of shut off. The mother's not coming, they've given up. All right. And you see this strategy as a way to cope with feelings later on in life. So avoidant people, when they get overwhelmed, they just kind of shut off. And you see more like dissociative disorders, PTSD, somatic form disorders, these types of people. With people with anxious disorders, see more like histrionic personality disorder, anxiety disorders, because they're acting out their feelings versus one's shutting off their feelings. And these are just separate ways to cope with emotion.
Right. Oh, wow. That's really, really fascinating. That's and again, this thing of broadening the perceptions, because here you are integrating aspects of attachment theory and finding it reframing itself. And
then you see these areas in the brain too, in terms of the cingulate cortex and how that responds to emotion.
Oh, so cool. And so that research, is that coming out, or is that just going on? Or
that stuff I published. If you go to my webpage, drfrancisstevens.com, you links to my publications on attachment theory, and then also on, I just came out with an article on empathy and looking at how empathy and compassion create pro-social behavior in the brain. So the neuroscience behind that.
Beautiful. We'll put links on the website on the page there for everyone to go to and to check you out further, and make sure, and we'll put links to the book, because everybody needs to get this book. It's just fabulous. What a great discussion.
I'm really excited about it.
Yeah, well, you should be.
I wrote it, I guess, right?
But
maybe I'm biased, right? I hope I'm not misattributing my emotion.
No, but we've got the same feeling. So attribution, and we absolutely concur. So thank you so much for coming on and talking with us today. We'll wrap up now, because we know our listeners sort of have enough after about 30 minutes or so.
I want to say thanks for having me. I always love being able to talk about psychology and this stuff. It's always fun. I love it. So anytime I get a chance to talk about psychology, I'm happy.
It's been a pleasure, Dr. Stevens. Thanks so much for joining us here on the Science of Psychotherapy podcast.
Take care. Bye-bye.
Okay. Bye-bye.